Good afternoon, everyone. My name is Jason Mouabbi. I'm a breast medical oncologist at the University of Texas MD Anderson Cancer Center, and I'm one of the editors at the Oncology Data Advisor, and I'm pleased to be joined today with two prominent doctors, Dr. Valerie Brutus, who is a breast surgeon at St. Vincent Medical Center in Bridgeport, Connecticut, and who specializes in the diagnosis and treatment of all benign and malignant breast diseases. She also specializes in oncoplastic techniques for breast conservation, sentinel lymph node biopsy, and skin and nipple-sparing mastectomies with immediate reconstruction. I'm also joined by Dr. Elizabeth Stirling Craig, who is a plastic and reconstructive surgeon at St. Vincent Medical Center in Bridgeport, Connecticut. She is one of few plastic surgeons in the country who specialize in microsurgery after completing a fellowship in reconstructive microsurgery at MD Anderson Cancer Center. Dr. Craig has extensive experience with advanced technique in microsurgery, such as what we're going to discuss today, lymphovenous bypass, flap reconstruction, oncoplastic lip reconstruction, and reduction surgery after lumpectomy. Today, we're going to discuss a very interesting topic, and which involves lymphovenous bypass surgery. Welcome to both of you. So the first question is, we need to identify what is lymphovenous bypass surgery? How can we define it to our audience? And we can start with Dr. Brutus.
Sure. So lymphovenous bypass is a technique that actually Dr. Craig, I'll let her talk to it about more. It's basically a technique in which the lymphatics are connected to a vein in order to help drain the lymphatic fluid that would otherwise accumulate in the tissue. And this is in patients who have to have an axonal dissection in part of their procedure.
I think Valerie explained it perfectly. The only thing I would add is that it's one of a few what we call functional lymphedema surgery options that we have, in that the whole goal of the surgery is to help reestablish or reconstruct the lymphatic system. So that's just one of the ways that other people have developed lymphedema surgery to help with patients after cancer.
Perfect. Now, when you see a patient in your clinic, who qualifies? Who do you offer it to? What are things that you are looking for to know that the patient qualifies or disqualify them from such a surgery? And we can start with Dr. Craig.
So for patients that come to see us for lymphedema surgery, we talk to them about all the types of lymphedema surgery. The functional types of lymphedema surgery are the patients that are in close proximity to that treatment. So it's not a chronic condition that they've been dealing with perhaps 20 or 30 years, but something that has relatively recently happened to them, maybe 1 to 5 years. We then diagnose the lymphedema in various stages, and depending on the stage that they're in and whether they get improvement with things like physical therapy, then we talk about the options that they may have for lymphedema surgery. There are two main types of lymphedema surgery that are functional. There's a lymphovenous bypass, which we're going to talk about today, and then there's a vascularized lymph node transfer, which is a little bit more aggressive of a surgical option.
And for the patients who
Anything you'd like to add, Dr. Brutus?
Yes, for the patients who qualify. So me as a breast surgeon, I usually am the first person to see patients on their initial phase of their journey for their cancer treatment. So far, we're offering immediate lymphovenous bypass in patients that we know are going to need an axonal dissection and part of the treatment. So we are reserving this immediate lymphovenous bypass as a preventive method in patients who have inflammatory breast cancer, patient presenting with axillary breast cancer, patient who have poor prognosis or poor response to chemotherapy. So these are node-positive patients who are undergoing neoadjuvant chemotherapy with poor prognostic response. So we know that those patients are going to need to have a dissection part of our treatment, but also this lymphedema risk is going to be higher because they also will need postoperative chest wall radiation. So when those patients, I see them identified, I see them knowing that this is probably a possibility. Those patients are seeing throughout their neoadjuvant treatment. then depending on their treatment response or the type of cancer, they are referred earlier on throughout their journey, because we know this is going to be something that's going to be part of their surgical treatment, and the hopes to decrease the risk of lymphedema.
Perfect. So since we already jumped into it, I want to ask the question officially. Is it more beneficial to perform it as a prophylactic measure at the time of breast surgery, or is it better to do it in a delayed fashion when lymphedema occurs? And can you speak to the success, which one is better, doing it at the time of surgery or later on?
Well, I can start, and I'll let Dr. Craig finish. I think, we all the data we have is sort of perspective. We don't have anything comparing, not doing lymphovenous bypass versus doing lymphovenous bypass. I think since we know that this is something that, a very big morbidity and also has a serious negative impact on patients' quality of life. So anything that I think should be offered as a prevention, it would be definitely the way to go. Because so far, once the lymphedema is established, I'll let Dr. Craig discuss which few treatment, can be proposed to those patients, but we unfortunately know so far that, there is no cure for lymphedema. So this is why, we're really trying to do this, as a prevention. And I think, there are some data to suggest that definitely, this offers a benefit, but of course, as time goes by, I'm sure that those data is going to corroborate, the benefit that this can in decreasing the severity of lymphedema in those patients who are at high risk.
Exactly. So I like to equate it to when you have, let's say, a leak of a pipe in your house, so we know that when you have water that leaks out one of the pipes in your house, and it starts to affect the walls and then sometimes the ceilings. In this case, if we do it immediately, we actually identify exactly where that leak is and we plug it immediately. We also know from a lot of studies that the lymphedema fluid in and of itself is very inflammatory. It's very reactive. So having that fluid leak out in any degree we know can cause scarring. Scarring is also going to impact the functionality of the remaining lymphatics. So I think from a conceptual standpoint, it makes the most sense to try to identify any problem we would have as it is occurring and identify it and essentially take care of it. There are preliminary studies that do show that in patients in comparable cohorts, they are retrospective, for patients that are going to have a full axillary lymph node dissection and radiation therapy. If we do an immediate lymphovenous bypass, it decreases the risk of postoperative lymphedema by 5 times. So I think a lot of it has to do, again, about just trying to limit the amount of leakage of that fluid, because it's that fluid that really is the most caustic to the whole lymphatic system.
Perfect, perfect. So how do you assess the patient risk of lymphedema? So that's the most important step, right, to see if they qualify for the procedure. So what are things that you are looking for to assess the risk of lymphedema? And if you can give us number, that'd be great, like percentages.
So I think, when we sort of look for general cause, of lymphedema, so we know that patient, who have elevated BMI are at increased risk for having lymphedema. It's also if patient had lymphedema of, for example, of the lower extremity that is not caused by any non-medical condition. So those patients, with sort of idiopathic lymphedema, so definitely those patients are going to patients that we know are going to be high risk. And I also think that, once we also know, the risks of Taxol are going to give lymphedema patient who had paroxysmal radiation or paraxillary surgery. So these are things that when we do our initial patient evaluations, all those questions that we go through, and then we address the disease process to say, okay, do we have axillary disease or not? How much of it? Is it bulky, non-bulky? So these are all things that we sort of do as initial assessment to say, who is someone that's already as increased risk for lymphedema, and knowing that our treatment is going to further, exacerbate that risk. So this is how we identify patient. I think, to know numbers. So I know historically what's been cited is, patients who are undergoing axillary dissection and who are going to have, additional radiation, they're going to probably have about a 35 to 40% risk of having lymphedema. But of course, that varies by different patients' population. So we know that some patients that risk might be higher and lower. So the way we assess those patients is, one, to identify which are the patients who are at risk. Two, which patients that we know that are going to require no intervention that's going to further exacerbate the risk. We refer all our patients to physical therapy, throughout their treatment, just to also have the patient educated about the lymphedema risk. And then when it's time for the patient to have part of their surgical treatment, Dr. Craig and I, have worked very well together, and we sort of, both of us evaluate the patient at, throughout the patient's treatment, just to see if this patient is a candidate. And this is when, more discussions are being, offered to patients about, this procedure. I'll let her speak, to that, but I think so far, as a team, we've been very successful. All the patients that, unfortunately are known to have increased lymphedema, when we're presenting them, this option, I think the patients are very excited and very grateful that they have an option that, can further decrease their risk, because, I think most patients now are aware, of what lymphedema is, and how also the negative impact it can have on their quality of life.
Exactly. So I think that Valerie does a fantastic job identifying the patients ahead of time that will likely be at risk. And then along the way, there's a constant dialogue between the oncologist, myself, and Valerie as to whether the patient would meet criteria or would benefit from it. Like we said, there really is no downside to it. We don't want to be necessarily in the armpit if we don't have to be there for even that much longer. This surgery in and of itself takes about 30 minutes, so it's not like we're in there for a lengthy period of time. So we really try to get in and out, and we're really trying to minimize any scarring or any more presence than we have to be there.
Just because the audience like numbers like myself. So let's say the risk of lymphedema is 50%. How much risk reduction are we anticipating from such a procedure? Like
If you go
hypothetical
by
case,
the
a patient
retrospective,
presents with a 50% risk of lymphedema. What do you tell the patient? What is, in an ideal scenario, how lower of a risk reduction are you expecting from such a procedure?
so say the patient we think is going to be at risk of developing lymphedema by 50%, we would say in the best circumstances, we would decrease their risk to 10%.
And how successful is such a procedure? Like, what's the success rate of undergoing a lymphovenous bypass?
So we know the success rate intraoperatively only because we're able to inject a dye that targets or shows us, it actually fluoresces lymphatic fluid. As soon as we identify the areas where it's leaking, like I said, it's kind of a pipe. We plug the pipe into the vein, we irrigate the area, and then we inject the dye again. And the whole goal is that there's no leakage at all. So the surgery is relatively new. We don't have long, 5-year studies quite yet to discern necessarily what that risk is going to be long term. But immediately in the operating room, you identify the leak, you take care of it, and the goal is that you don't leave until it's taken care of.
Perfect. Now, the other question that somebody might ask is, let's say we're not doing it prophylactically. Let's say we're doing it because lymphedema is established. Two questions comes here. How long does it take to see the benefit? And when do we say it's not beneficial? Like if we don't see improvement after how long we would say it wasn't a successful procedure? Number one. Number two, if symptoms are available. So if patient is having discomfort, pain, redness, swelling, do we expect those symptoms to go away? And what symptoms will you would expect to improve, and which one will not improve with such a procedure? And this question is for both.
So I can start. So when, part of our follow-up for our patients, all patients, we always do, limb measurements to assess for lymphedema. We also have a lymphedema questionnaire that assesses, the patient's perception of lymphedema, and if this is present, the impact it has on the quality of life. So by doing that, we really want to try to identify the lymphedema as early as possible. We know that with the different stage of lymphedema, once a patient gets to this stage, which is, I think, stage 4, when there's fibrosis, So definitely there's not a lot of treatments that are available at this time. So ideally, we would like to offer this to patients, if patient did not have the option to have this as a prevention, and patients who started to have early on symptoms, because we know that with all the data that we have for lymphedema treatment, early intervention, whether it was before, by external techniques such as massage or compression garments or any types of other garments that could help, simulate the lymphatic massage, have all shown us that the earlier we can intervene, for lymphedema, the better the chance of success. So what we're doing now is being very aggressively monitoring our patients for signs of lymphedema. Of course, once the patient starts to have early signs of lymphedema, surgery is not the first step. So this patient gets referred to physical therapy. We are very lucky to have, lymphedema trained physical therapists that we work with very closely. So if those patients, continue to, I would say, progress, despite aggressive, physical therapy, I think those patients are the one that we definitely start to consider to talking about, surgical intervention with them.
How long do you
And
wait?
this is
Like,
where I send them to
for
that.
example, for bariatric surgery, it's 6 months with a dietitian before we do it. Here, how long do you wait for PT to take effect before taking up surgery?
I think it's going to be, definitely between 6 months to a year, because we know that there's different ways, to evaluate the patient's arm measurements, but all the measurements agree that once there's a difference in 10% of the lymph volume, lymphedema is present. And we know that with the physical therapy, we have to give them, at least 6 months to try to see, if there is any progression. So I would say that, if the patients are, when we have to make sure that the patient is compliant, that there's no contraindication for them to get physical therapy, and that, they're really following all the recommendation, wearing a sleeve and following all lymphedema precaution. And I think, those patients are usually measured pre-treatment, post-treatment, they're remeasured after 6 months, 9 months to a year. So I think we need to at least have 2 measurements to say that there is progression of this lymphedema despite treatment before we start to discuss, surgical intervention with those patients.
Perfect. Dr. Greg, same question to you. If we're doing the surgery as a delayed fashion, so when lymphedema has already occurred, what is the time frame we expect to see improvement in patient? And what symptoms does it alleviate, and which symptoms it would not alleviate of lymphedema?
That's a good question. I think, as Valerie was saying, the key really is this constant dialogue between us, oncology, and the lymphedema physical therapist. So if the lymphedema physical therapist believes that really they have plateaued, then they are pretty quick to reach out to our team to institute a surgical intervention because it's clear that they are not having any improvement. From a physiologic standpoint, because that lymphatic fluid is so inflammatory and it induces scar, we want to intervene sooner rather than later so we can prevent that area from leaking, so we can try to have the lymphatic system up and working so that there's a minimal amount of fluid that's irritating the existing lymphatics. So when I was at MD Anderson, we would try to say, between 6 months and a year of essentially physical therapy plateauing, you want to intervene surgically. So just like any reconstruction, the sooner the better that you can get in there, the more success rate you will have. Between the two types of lymphedema surgery, the lymphovenous bypass and the vascularized lymph node transfer, the studies are quite variable, but for the most part, early stage 1, 3, through 3, will undergo lymphovenous bypass because there is no downside to it whatsoever. It will never increase your risk of worsening lymphedema. It does not place you at risk of infection. So there's little hindrance to undergo that type of surgery. If anything, it can only make it better. If you go by the studies, it's about 60 to 80% of patients that undergo lymphovenous bypass will have some improvement. In my experience, you'll see most of that improvement within the first 6 months. And at about 9 months to a year, it plateaus. If you see them, which I do at about a year, that's as good as it's going to get. You can do repeat lymphovenous bypass, which is not something you can do with the vascularized lymph node transfer. So it's not uncommon for us to stack lymphovenous bypass on patients. In essence, the patient comes back every year, has improvement of a certain area, and comes back again the following year to have lymphovenous bypass, let's say in a more proximal area. And eventually, hopefully, you get to the point of whatever their goal is, whether it's wearing a shorter sleeve or not wearing a sleeve at all. As long as they're seeing some improvement, we can continue to do lymphovenous bypass because we know we're not impacting the large lymphatic systems, we're impacting the small lymphatic systems. We're trying to offload the larger system so that it can function better in essence. But the vascularized lymph node transfer is reportedly more successful. You'll see reports between 80 to 90%. The problem with that is oftentimes those patients, you have to wait at least 18 months, so a year and a half to see any improvement. So that's not ideal in somebody who is, at stage 3, because very quickly you hope that by the time that lymph node starts working, maybe it's not in a favorable environment that could even function.
Perfect. Now, I know we talked about it here and there, but I really want to ask about the technique a little bit and the times. I know we said half an hour, but I want to re-emphasize about those in this question. So let's talk a little bit more about the technique. So we said there is 2 different surgeries that we can do. We can do either the bypass itself, or we can do a lymph node transplantation. Where do we harvest those lymph nodes from? Where do we get them from? Can it be done at the same time of surgery, of breast surgery? Or it has to be done separately? How much each procedure adds to the breast surgery procedure? So if we can talk about them in the session, it'll be excellent.
Sure. The lymphovenous bypass can be done immediately. And like I said, it doesn't add that much extra time. It's done about maybe extra 30 minutes or so. The vascularized lymph node transfer, usually if you're doing it, for example, a breast cancer patient where they have lymphedema of the arm, you're going to try to borrow a lymph node from another place in their body. And that's oftentimes in the leg. You can borrow it from different places in the next to the clavicle, kind of below the mental area. Those scars are not very well accepted by Americans, so most of those surgeries are done in Asia and other countries. But the majority of the vascularized lymph node transfers in the United States are done in the groin. So we do reverse lymphatic mapping to identify the lymph nodes that are draining the leg, and the lymph nodes that are draining the abdomen, and ideally take just a few, 1 or 2 lymph nodes that are draining the abdomen and not the leg. The goal is to avoid, obviously, incurring lymphedema on a poor lymphedema patient in another limb. So that's why we do the reverse lymphatic mapping, and we do it at the same time as breast surgery if essentially Dr. Brutus thinks that would be the best thing for the patient. It really is one opportunity that you have to transfer that lymph node. So that's where I really rely on Dr. Brutus and the oncologist to tell me what they think the patient's going to need for treatment and whether they would recommend that we do that immediately at the time of the mastectomy, or is that something we really should reserve until they're done with their treatment?
Anything you'd like to add, Dr. Brutus?
Yeah, so my part so far, I've only worked with Dr. Craig in doing, immediate lymphovenous bypass. So when we do the reverse lymphatic mapping, that's probably one of the most important part, of the procedure, because it really first help us identify, which lymphatics that we can safely spare, because even when we're doing, lymph node dissection, we try to, some lymphatics, if they're not connected to lymph node that we have to remove. So if you can spare those lymphatic, we spare them. That also help us identify if we have a larger lymphatic channel. We usually try to dissect them as close to lymph node as possible, so we can at least preserve some of the length of those lymphatics. So all of those are things that, it's really important to have just a good communication to know why are we doing this, what lymphatic that we can spare, the one that we cannot spare. If we try to preserve the length of those lymphatics, that we tag them doing, after they're cut, as long as possible, they're tagged, so to see if those lymphatics can be patently reconstructed. Also when we're trying to dissect, veins, we usually try to at least leave some tail of the vein, not cut it too short, so we can preserve the length and just to allow, to have at least amount of tension as possible. Dr. Craig, when she does it, most of the time she used, a vein patch just to help alleviate this tension, on the connection. And, so far, our patients, they're having a pretty good, postoperative experience. We do a lot of, nerve blocks before they start. We have a very good pain management team that's on board. And those patients, are very comfortable. And it's just add an extra half an hour, when to the procedure after the dissection is performed.
Amazing. Very insightful. So we talked about the benefit of such procedure, and I've heard you very well that it's very well tolerated, but what are some of the side effects of such a procedure, both short-term and long-term, that somebody should be at the lookout for?
I think probably the short-term, side effects, the patient's gonna have an extra scar in the leg if we do, the vein patch. So, they have a donor side that they have to heal from. Honestly speaking, I think in terms of other short-term side effects, there's not a lot, because it's probably the side effects all get looped into the regular side effects that we're gonna have from a dissection point. So most of it is comfort and pain, just from the lymph node removal themselves per se. The reconnection, of those lymphatics does not really create, a bigger problem. Of course, whenever you're dealing with lymphatic anastomosis, you can always have, bleeding, from those connections or leakage from those connections. So I think that could definitely be considered, as a possible, immediate, side effects. But I think in those procedures, where we're already working closer, to major vessel, for us, being crucial and careful in our dissection, is key. So I feel like when we're working, we're already, so concerned to preserve the length of the lymphatics, the length of the vein. We're very concerned to have, very great hemostasis, so not to have any complication from the surgery itself per se. So I think, overall, the immediate side effects are, very, very minimal. Long term, I think also, they're going to get lumped into, the complication that we're creating from having an extra dissection. So a lot of patients after this procedure always report, some heaviness of the arm. They have restriction, for the first 2 weeks with movement, so they get some shoulder stiffness. So that's why we're very aggressive, and we have a very good PT team that, once they're cleared, they get referred for range of motion exercise. So I feel that this small connection itself per se, we both of us don't see it such as, an extra step that's going to add, an additional complication, for the procedure.
No, I agree. Oftentimes when we're talking to the patients, they sometimes say, is there a catch? And I really don't think that there is one in this situation. You're already going to be in the armpit, so just merely taking an extra half hour to reconnect things really does not place the patient at additional risk. And I think that's why Valerie and I are both really passionate about trying to get the word out about this for patients, because there really is such a little downside to it. It just doesn't take that long. The patients seem to do great, and if it is as impactful as we think it is, I think it really could help with the growing population of lymphedema patients that we have.
Perfect. Just one last question. For our patient and patient advocates that are listening, how widely available is this procedure, and is it reimbursable by commercial insurance and by Medicare or Medicaid?
So it is a billable service from a provider standpoint. So it obviously that changes regionally, but since it is covered by Medicare, usually CMS will kind of follow suit, and the commercial providers will reimburse for it as well. That doesn't necessarily mean that every institution is going to be trained in it and offering it. Certainly large cancer institutions like ours, like MD Anderson, Dana-Farber, it's kind of a growing procedure. I would say, it's rather in its infancy. The preliminary results, I think everybody is very excited about. And that's why Valerie and I, talk a lot about it and try to get the word out amongst the patients so that they can be their best advocate and request it wherever they are.
Anything like to add, Dr. Brutus?
No, I completely agree. And I think, it's great that we're able to offer this, types of procedure. I said, Vincent, medical center, of course, not all patients have access to go to big cancer center, but I think having this done, locally it's really good. And I think patients just have to know, what their options are, and to also understand, to why is it beneficial, and just know that this is an option for patient that we know who have, either we're going to have increased risk for lymphedema or already have lymphedema, from pre-existing cancer treatment.
I mean, this has been great. I can tell you from my experience with my patient, it's been like godsend procedure. It really helped patient and it really improved their outcome drastically. Any last remarks before we conclude?
Yeah, I think as the data is going to start, to come along, it's probably going to be a practice changing, procedure. I think it's going to be something like the same way, when sentinel node biopsy came, to try to downstage and offer patient, less aggressive procedure, or decrease the morbidity of the procedure that we have to do. I feel like as the data is going to come, this is something that's going to be offered pretty sort of routinely to all patients who has to still undergo axonal dissection, or patients, who have progressive lymphedema that is from their treatment that's not improving by physical therapy.
Yes, no, I would just echo what Valerie says, and feel free to reach out to us if you're in the state of Connecticut, or if you have any other questions. We're here to help. Absolutely.
Of course.
Thank you. Well, that's been great. Thank you for all our audience for listening in today. And I want to thank Dr. Brutus and Dr. Craig for joining us in this very interesting discussion. Thank you very much.
Thank you so much. Have a nice day.
Our pleasure.